The human brain is an organ with high energy density demands, amounting to only 2% of the entire body mass, that is 1.4 kg, but accounting for about 20% of the total power consumption of a normal adult at rest. Blood perfusion is responsible for the delivery of oxygen, which is necessary for the neuronal oxidative metabolism of energy substrates, most commonly glucose, but also ketone bodies and lactate. High blood pressure profoundly influences the cerebral circulation, causing adaptive vascular changes and an increased incidence of stroke, both ischemic and hemorrhagic. Regulation of cerebral blood flow. Using a simplified approach, one can divide mechanisms that regulate cerebral blood flow into 4 distinct components or adaptive responses: autoregulation, chemoregulation, neural regulation, and endothelium-dependent regulation. The first mechanism, termed autoregulation, relates to the response of the cerebral circulation to changes in cerebral perfusion pressure. Autoregulation is the intrinsic ability of an organ or a vascular bed to maintain a constant blood flow in the face of a varying perfusion pressure. Cerebral perfusion pressure is determined by blood pressure, intracranial pressure, and venous pressure. The cerebral resistance vessels in normotensive individuals are known to autoregulate across a broad range of mean arterial pressure. Perfusion pressure below the lower limit result in initially increased oxygen extraction from hemoglobin and subsequently global ischemia. Pressure above the upper bound may result in breakthrough, edema, hemorrhage, seizure, and posterior leukoencephalopathy, that is, hypertensive encephalopathy. The normal autoregulation curve may be right-shifted in chronically hypertensive patients, although the magnitude and the duration over which this occurs cannot be determined on an individual basis. Autoregulation maintains cerebral blood flow relatively constant between 50 and 150 mmHg, means arterial pressure. The range is shifted in chronically hypertensive patients. Autoregulation has a lower and upper blood pressure limit and respond also to intracranial pressure changes. The mechanism of cerebral blood flow autoregulation may be a combination of myogenic and metabolic factors. The limit of autoregulation are influenced by the level of cranial blood flow. At high cranial blood flow, example, during hypercapnia, the autoregulatory plateau is shortened, the lower limit being shifted toward higher pressure and the upper limit toward lower pressure. Conversely, at low cranial blood flow, the autoregulatory plateau is broadened. The limits of autoregulation are also influenced by alpha-adrenergic perivascular nerves and the renin-angiotensin system. Impact of normally functioning autoregulation, that is, functional autoregulation leads to regulation of cerebral blood flow, regulation of microvascular pressure, protection of the blood-brain barrier. Consequences of impairment in relation to brain health, that is, dysfunctional autoregulation leads to hypoperfusion or ischemia, syncope, hyperperfusion, altered microvascular pressure, loss of blood-brain barrier integrity plus edema. Microbleed leads to cognitive dysfunction or non-cognitive dysfunction. Modifier of autoregulation: hemodynamics, O2, CO2, pH, endothelium, neurons, metabolism, vascular stiffness, vascular structure, behavior, posture, genetics, temperature, vascular risk factors, and vascular disease. The second mechanism is chemoregulation, another class of vascular reactivity. This includes vascular responses to changes in carbon dioxide and subsequently pH, partial pressure of oxygen or O2 content, tissue acidosis caused by hypercapnia and or hypoxia lead to a high cerebral blood flow, and tissue alkalosis caused by hyperventilatory hypocapnia leads to a low cerebral blood flow. Extracellular potassium and adenosine also influence cerebral blood flow. The third mechanism is neurogenic, consists of the influence of nerves and neurons on cerebral blood flow. This includes the local cerebral blood flow response to nearby intrinsic neuronal activation within the brain parenchyma, but also include effect of autonomic and sensory nerves. extrinsic innervation on the extraparenchymal segment of the cerebral vasculature. The perivascular alpha-adrenergic nerves, although not influencing vessel tone at rest, can be activated at extremes of blood pressure to constrict the larger inflow tract resistance vessels. Thus, during hemorrhagic hypotension, alpha-adrenergic constriction of the larger resistance vessels oppose autoregulatory dilatation of the smaller vessels. The net result being a shift of the lower limit of cerebral blood flow autoregulation toward higher pressure and a tendency to inhomogeneous tissue perfusion. A fourth mechanism relates to the effect of vascular endothelial cells on vascular tone and therefore cerebral blood flow. In response to hemodynamic stimuli, ions, neurotransmitters, metabolic stimuli, and therapeutic agents, among other factors, the ability of endothelial cells to cause vasorelaxation. Endothelial dysfunction, a feature of many forms of large and small vessel disease, can therefore have multiple consequences, not only on cerebral blood flow, but also on other endpoints related to brain health. Furthermore, endothelium-dependent effect on platelets, immune cells, neurons, and glia each involve target cells and keep brain in normal function. Endothelial cells also inhibit processing of beta amyloid and phosphorylation of tau, both major contributors to Alzheimer's disease.